So patients living with PSC are symptomatic, and at present they don't have licensed treatments for their disease or all their symptoms, really, in essence. And itch is a really awful symptom to live with in PSC. In the VISTAS study, it's a very rigorous randomized controlled clinical trial with placebo against Volixibat dosed twice a day. And the itch is measured in a very, very specific and highly analytical and appropriate way using the Adult ItchRO score. And what we saw in the data really was clinically meaningful improvements in itch. Yeah, the way I look at the data, you can see clear separation between treatment and placebo. When you then look at the primary endpoint, you can see a clear change between treatment and placebo. The exact number is 1.64, but these numbers, mean more to regulators than to patients. The patient benefits even greater. I think the way I like to look at the data is I look at the longitudinal change in the itch, and I see a rapid and immediate separation between the treatment and the placebo for the average pruritus score, with a really important delta. And then we know that the clinically meaningful improvement in pruritus is considered to be a greater than 2-point reduction in the ItchRO, and nearly 60% of patients on treatment had that clinically meaningful improvement pruritus, whereas only 1 in 4 patients on placebo. So all in, this trial is actually very exciting for patients because we've got a class of drugs where we know that they're antipruritic based on how they work. And now we've got really robust data in PSC from a randomized controlled clinical trial. So I think patients will be very happy to have this option. Know what the pruritogen is in cholestatic liver disease, but we do know that almost certainly it's released by the hepatocyte, and almost certainly bile acids are part of what is released to make our patients with cholestatic liver disease itch. When you take an IBAT inhibitor, what you do is you shift the recirculation of bile acids away from being fed back to the hepatocyte and into the colon. So the hepatocyte receives less bile acids, and as a result, the hepatocyte secretes less pruritogens. And there's lots of speculation about what those pruritogens are. As a class of drugs, this is exactly how IBAT inhibitors work. And as an IBAT inhibitor, Volixibat is very specific and does exactly what you would expect. It turns the bile acid recirculation to the colon. Less bile acids go back to the hepatocyte. The hepatocytes receive less bile acids. As a result, the hepatocyte releases less pruritogens. So that's why IBAT inhibitors, including now with this randomized controlled clinical data from Volixibat, are definitely antipruritic agents in cholestatic liver disease. The whole history of how we got here actually goes back to before we had all these drugs, and Volixibat's going to be a trailblazer for PSC. We used to put patients to have something called a nasobiliary drain, and they could have this tube put in, and we would drain the bile out of their nose essentially instead of it recirculating, and that was an effective treatment for itch. It just wasn't very sustainable. So now we actually have a chemical treatment that is chemically interrupting recirculation of bile acids, and that leads to the release of less pruritogens, and that's why you see as a class of drugs, both in pediatric and in adult cholestatic liver disease, in PBC and in PSC, that IBAT inhibitors are antipruritic. Different questions when you think about the other secondary endpoints in the clinical trial. The most important endpoint is that the drug does what you'd expect for an important symptom. The patients are less itchy and it's a sustained effect. I think the change in bile acids is very useful to see. It's really helpful to have a biomarker of drug efficacy with some quantifications. So, the fact that we can see a fall in bile acids on Volixibat tells us that the drug is working mechanistically as we'd expect. As regards to the other symptoms, I think I look forward to seeing more data. At the moment, it's only been a conference procedure. We do expect that when you improve itch, you would also have an improvement in sleep disturbance related to pruritus, and I think that's what we see. We'd like to see whether or not that then translates into other symptom improvements, but at this stage, it's quite early days in terms of those analyses. But for sure, patients will be looking to see beyond sleep whether or not there's an improvement in fatigue. But I am mindful to remember and to remind people that fatigue is a very complex symptom. And there isn't a complete immediate overlap between fatigue and pruritus. So it's quite possible that drugs that improve pruritus and sleep disturbance related to pruritus may not directly have a quantifiable improvement in fatigue. So I look forward to more data. When you're developing a drug for symptoms, patients want to feel better, and they want to feel better quickly after starting the medicine. In this clinical trial, and actually very similar to other IBAT inhibitor clinical trials, because of the mechanism of action, because of the way an IBAT inhibitor changes bile acid recirculation, it is predicted that you'll have a very rapid onset of improvement in pruritus, and that's exactly what you see. So, within a few weeks, your patient will know that they feel better, and that's exactly what patient wants. And if patients have drugs that improve their symptoms that quickly, then they'll stay on the drugs. Because when you're treating a symptom, it's like if I told you that you have a headache and I'm going to give you Tylenol, but you have to wait a month for the Tylenol to work, you're not going to take it. So it's exactly the same. If I tell a patient who's got cholestatic pruritus due to PSC and they're feeling miserable and they're scratching until they bleed, that I have a treatment that within 1 to 2 weeks, they'll be able to tell immediately that it's helping them. That's patient-centered care. So I think it's really great. The bottom line is it's very difficult to develop drugs for PSC. So it's phenomenal to have a clinical trial that works. It's phenomenal to have a clinical trial that addresses a symptom that's important for our patients. So I hope that this data is sufficient when presented to regulators, that this means that patients will have access to a drug that improves their symptoms, which, even if it's not, only patients are looking for more than just symptom treatment. Of course, they'd like disease modification, but even that small step in the right direction, that they know that there's a licensed treatment that's been developed specifically for them, that's been trialed specifically in PSC, is a huge advance for the field, because it brings a lot of optimism that not only can I help my patients feel better now and with a rapid onset and a sustainable onset, but that ultimately we will also then develop drugs eventually for disease modification. So I think it's good news. Obviously, there's a long way to go, and there's a long way to go from a conference presentation to a licensed therapy. But this is a pretty good start. I mean, people are always going to want to talk about safety of drugs. So it's always important to remember this is a drug that's part of a class of different IBAT inhibitors, and that what was reassuring for the audience who listened to this presentation and for patients is that there were no new safety signals. So the safety data that was presented was consistent with what we've seen for other IBAT inhibitor clinical trials. So there's no doubt we need to learn how to use these drugs in the real world, but it was reassuring that when listening to the presentation, there was nothing that hasn't been discussed or described from previous IBAT inhibitor clinical trials. And there are many IBATs now available on the market. So I think that will reassure patients.